Good afternoon, everyone. This is Doreen from the New England QIN-QIO, and I'll be moderating today. Thank you for joining us for today's webinar, Journey to a Successful Antibiotic Stewardship Program in a Small Rural Healthcare Facility. Before we get started, I have a few housekeeping items. This call will be recorded for training purposes. The presentation is available on the event webpage. The link has been posted in chat for download. All lines will be on mute for the duration of the presentation. Please don't put us on hold. We'll take a few questions in chat at the end of the presentation if time allows. We encourage you to post questions in the chat feature, and please make sure to send your questions to all participants. If you need to speak at the end, press #6 to unmute your individual lines. At this time, I'll pass this over to Amanda Gagnon, also with the New England QIN-QIO. Go ahead, Amanda.
Hi, everybody. I'm Amanda Gagnon. I work with the QIN-QIO. I'm a program coordinator. My focus is on antibiotic stewardship, quality reporting in the hospitals.
The leader has muted your line. To unmute your line, press #6.
Amanda, can you press #6 and presenters to unmute? Thank you. Sorry.
That's okay. So my name is Amanda Gagnon. Welcome, everybody. I am a program coordinator with the New England QIN-QIO. My focus is on antibiotic stewardship, quality reporting in the hospitals, and care transitions as well. I'd like to introduce our two presenters today, Dr. St. Pierre and Dustin Butler from Northern Maine Medical Center in Fort Kent, Maine. Dr. St. Pierre has been a practicing emergency physician since 1994 and a medical administrator since 1997. Dr. St. Pierre has been the lead physician and co-chairman of the Antibiotic Stewardship Committee at Northern Maine Medical Center since inception in 2016. Dr. St. Pierre traveled to Atlanta in April of 2017 to serve as an advisor for the development of the policy for the implementation of antibiotic stewardship in small and critical access hospitals by the CDC, AHA, Pew Charitable Trust, and HRSA. Dustin Butler is a PharmD. He's the pharmacy supervisor at Northern Maine Medical Center, which is a 49-bed acute care facility with a 6-bed intensive care unit and 7 affiliated outpatient offices. Dr. Butler formed and led an antibiotic stewardship committee with Dr. St. Pierre. They developed a program to decrease the use of antibiotics, decrease resistance of bacteria to antibiotics, and ultimately improve patient care. I'd just like to say that it's important to know that today's speakers have no conflicts of interest to disclose. And now I'm going to pass it over to our presenters.
All right, so I'm going to start off. This is Dr. St. Pierre here. I'm going to start the presentation and then pass it over to my colleague Dustin as we go along. I believe that we're not, okay, there we go. Now we get advance our slides. So just to discuss a little bit about what is antibiotic stewardship, that's kind of our official definition there. But honestly, it's really a judicious use of antibiotics to try to decrease antimicrobial resistance and the development of opportunistic infections. And hopefully during this whole process, we can improve medical care and also hopefully help control costs by causing less money spent on unnecessary antibiotics and then having to deal with the complications that those unnecessary antibiotics have caused. So the next slide here is talking about objectives. And this is going to be the objectives of the presentation today. The first thing is to make a splash. And what we mean by that is basically just to, make it so that people realize this is really important. We're going to talk a little bit about selecting the right team members, which is really important if you want to get things accomplished. Allocating limited resources, because we're a small hospital and we don't have a lot of money to spend on this type of things, and we really have to figure out the best way to use our money. Next part of it was to gather baseline data. we'll chat a little bit about that because you need to know where you're at before you can get started. And then developing a standardized evidence-based protocols or algorithms, which is something that I designed on various conditions and infections, and we'll talk about that a little bit. We'll talk about how we educated our staff members, not only our medical staff, but also our hospital staff. And then once we got the project going, how do you gather post-implementation data to see if you're making a difference? And then what's really important is at some point in the future, you actually have to reassess and say, is this really making a difference or not? And then we'll talk a little bit about tips and pearls and things that we ran into that worked and didn't work. And finally, we'll end it all with what's next for our program. So, making a splash. I have to give credit to Dustin for this. He was the one that did the original ground rounds presentation back in September of 2016 that introduced this topic of antibiotic stewardship and antimicrobial resistance. And really, I was sitting during that presentation and I was like, wow, this is really important because, this is causing a lot of problems. We're developing antibiotic resistance. We are developing these development of superbugs, and if we don't do something really quickly, this is going to cause some pretty serious problems down the road. He was able to bring in kind of all the different, data and statistics, and it really was eye-opening to me to see exactly what it was. So with that, we were able to identify the problem and also provide the why we wanted to do this. So at the end of that grand round, I got together with Dustin and I said, listen, we really need to do something about this. So the first part of what we needed to do was to actually build a team. So we decided to go with a two-leader, co-leader program. And I'll give you the reasons for that is that basically I think it's really important to have a physician leader and also a pharmacist leader in this. The ability to have two people that's leading your team is good in the event that something happens, somebody leaves, or decides that they're going to move on to something else. It doesn't mean that your whole committee no longer has a leader. And the second thing is oftentimes I find physicians seem to take directions better from their peers than they do sometimes from other members of the hospital. So it does allow for that. And I find that pharmacists in general are very structured, organized, and have a really good knack of getting things going and making sure that we stay on track. So that's why we developed this. Now, people may be looking at this and saying, why in the world would they choose an emergency room physician to lead this team? So, first of all, we're a small 50-bed hospital in the northeast of the United States, and we do not have an infectious disease specialist that could have led this team, and our nearest one is probably at least 2 hours away and probably even more towards the 4 hours away. So they decided to choose me because A, I had interest in it, and 2, I was probably one of the worst offenders of the improper use of antibiotics as an emergency physician. So I think by saying if Dr. St. Cyr can change, then everybody can change, that was probably part of it, is why they just decided to choose me as a leader. And I will say that over the past 2 years I have changed, and things are going significantly better on that aspect. As for the lead pharmacist, Dustin has some special training in infectious disease, so he was an ideal choice for this. The other members of our team is we did have an infectious disease specialist at one of the tertiary hospitals that volunteered to act as a consultant if we had any questions. But honestly, we've used them very little and only in very selective cases do we use them because they are so busy and their availability is quite limited. Important members of the hospital team administration, you're going to have to allocate resources. You need administration buy-in to set up a program like this. Once you've convinced them of all the good things that an antibiotic stewardship program can do, and honestly with the new Joint Commission accreditation guidelines, I think they understand the importance of this for their own accreditation and regulatory bodies that are watching this. So I think there is buy-in now. From a lab standpoint, we not only had the lab director that was involved in building our team, but we also had the head of the microbiology department who was instrumental in providing us with antibiograms to know exactly what our resistant patterns were, and also to keep track of how things were progressing. Obviously, we had our infection control nurse, and we had members of the nursing staff, since nurses are also extremely important in being able to help keep us on track when it comes to the administration of antibiotics, collecting blood cultures, following our algorithms and such. So it's definitively important. The Department of Quality were the ones that were actually helpful in gathering the baseline data to help us determine where we would get started in this. And then they were also the ones that would help monitoring quality outcomes. And the two things that we're really concentrated on was outcomes. We wanted to see if this program was making a difference. And compliance, were the providers, physicians, and practitioners, and physician assistants actually sticking with the algorithms that we had devised and actually following them. The IT department was extremely useful at helping us integrate this into our hospital intranet, since that was an essential part of what we're doing. And finally, we had our public relations person who helped structure this so that we could educate the community on the importance of antibiotic stewardship. Because one of the biggest problems and challenges is the majority of people are, we've got a cold, we've got bronchitis, we need to get some antibiotics right away. And it was to try to change that general mentality amongst our community members. And we did that through our public relations department, is what we did. So the issue of allocating limited resources, as we mentioned, we're a 49-bed, non-critical access hospital in Northern Maine. And I believe all hospitals of our size are struggling in this new healthcare environment with dollars, so we don't have a lot of money to spend. Trying to hire an infectious disease specialist was out of the question to come and structure this for us. So we really had to take our existing staff members, directors, administrators, and people such as myself and kind of give them roles in this to get our committee started. And actually, I think once you've made that splash, I think people realize the importance of this and are pretty dedicated to help make changes. So that's what we did. We did not get any extra money from administration to do this, but I mean, we do have the goal over the long term to try to save some money on antibiotic use and decrease complications. We formed a very efficient team. It was a small group of people, probably about anywhere from 8 to 9 members. At times we would bring in a hospitalist physician or a surgeon to give input, but then at other times we'd bring in maybe an outpatient doc to help structure things on an outpatient basis. The most important thing that I think I have to stress is that this committee has to be organized. When you first start, you have to set very clear goals, and you have to have frequent meetings. And I believe we met probably bi-weekly initially, and then spread it out to monthly, and we've been meeting monthly since 2016. And when we meet, we actually take minutes of those meetings. We assign roles and tasks to people, and we come up with action items at the end of each meeting with the intention that these people go out and have certain roles and tasks that need to be done prior or before the next meeting, which sets up accountability. And that's really the key to success, is to make sure that you have accountability and everybody is doing that. I'm going to shift over to Dustin now, because he was the person responsible for gathering baseline data. So go ahead, Dustin.
Hi, this is Dustin. So after you get your team members together, you need to start gathering some baseline data. This is a multi-department collaboration, so you almost have to work with every department in the hospital to make sure you can get the data that you need. Some of the data to collect, you need your resistance data. So you're going to pull your antibiogram from your lab or microbiology department to kind of see where you stand with resistance among different bugs. You also want your MRSA and C. diff rates as a baseline, because those are two major indicators that you want us to improve as part of this program. Also your prescribing patterns. So you want to see how your docs are doing with prescribing antibiotics for various indications. And you want to target the most relevant diagnoses. So some of the top ones that you can think of offhand are pneumonia, sepsis, UTI, and more for the outpatient side, bronchitis, sinusitis, UTI, and indications like that. You also want usage data. So you want how much antibiotics are actually being used at your facility. And you want to make sure it's a standardized measure. So we use defined daily dose over the patient days at our hospital. The calculations for defined daily dose can be found on the CDC website. So for each antibiotic, it tells you how much of a dose is considered a daily dose. And you want to also check on how adherent your providers are to documentation. So it's very clear what documentation is needed as part of prescribing antibiotics. So you want to make sure they're following that along the way. Another part of gathering the data is you want to really boil it down to one disease state at a time to keep it manageable. You can't monitor everything at the same time, especially in a small facility like ours. We have limited resources, so really target one at a time. Examples, the first one we did on the inpatient side, we targeted sepsis, and the outpatient side, we targeted bronchitis. So some of the baseline data that we do have is we were monitoring susceptibility and resistance. So the first one was systemic Pseudomonas. So if you look at our graph at baseline, Cipro and Levaquin had quite a bit of resistance. So as part of making our algorithms, we actually tried to curb away from prescribing those just because the resistance patterns were headed in the wrong direction. The next one that we looked at is systemic MRSA. If you look, clindamycin doesn't do that well, so we made sure that wasn't part of our algorithms. Next one was E. coli in the urine. If you look at this one, nitrofurantoin really does well, so that was our number one on our prescribing algorithms. Again, the fluoroquinolones don't do too well. There's quite a bit of resistance there, so we tried to kind of curb away from providing those. So what we came up with for our baseline data, just to give you some measurements, our MRSA rate was at 41%. Inpatient prescribing rate of antibiotics was 23%, and that was using the time daily dose over the patient days. Outpatient bronchitis prescribing rate was at 35%, which should be 0. Inpatient adherence to the sepsis algorithm was 73%, and adherence to the documentation was 50%, and that documentation part is really a tough one.
So I'm going to take back over from here since that was the one that helped develop the protocol for the evidence-based practices. Basically, what we wanted to do was to figure out what diagnoses were we actually going to focus on, what infections, and we wanted to look at the outpatient setting, the inpatient setting as like a hospitalist, for example, and then the inpatient setting as a surgeon. So what we ended up doing is looking back through having our information systems department go back and see what our most frequent diagnoses are. And I'll go just a little bit slower in case you guys want to write these down. But from an outpatient setting, what we did focus on was otitis media in children, sinusitis, bronchitis, the non-use of antibiotics for that specifically, COPD exacerbation, cellulitis, UTI, pneumonia, and pharyngitis. So we had 8 things that we did as an outpatient that we wanted to monitor and develop algorithms for. The inpatient side for hospitalists, we did COPD exacerbation, pneumonia, sepsis with an uncertain source, and cellulitis. And from our surgical standpoint, we looked at appendicitis, cholecystitis, and diverticulitis. And the way I made up these algorithms was one of our outpatient physicians said, please keep it simple. Just use some flow diagrams that the doctors can easily follow and decide this is what the infection is, whether there's penicillin or not, and these are the drug choices. And that's what we did for each one of these, with obviously some different choices of antibiotics for each one. And we can get those to you if you have interest in seeing those. But that's kind of how we got started, and we focused on the outpatient, inpatient, and surgical protocols. As you can see, this is an example of one of our inpatient pneumonia protocols and how we need to follow those. Now, what we've been doing also is when we start checking to see if people are compliant with following these, we really only choose one at a time. That way we can best allocate our resources. It would be impossible to try to review each one of these at the same time. So once we actually set up these algorithms, I then took over and did a grand rounds presentation for all the medical staff on the algorithms themselves, the importance of antibiotic stewardship, where we are with our data, and where we want it to be. We placed these algorithms on the employee portal on our hospital intranet. We distributed flyers with all of these algorithms on it. From an emergency room standpoint, as the emergency room director, I actually did direct feedback, peer-to-peer education with all of my docs on what the algorithms are and what our expectations were and how they were to treat infections in the ER. And then once we started getting results back, then I could actually do targeted education based on performances by actually comparing peer to peer, which really makes a big difference when you want compliance to occur, because most physicians want to, be part of the norm and not the exception. And I'll go back to discussing about post-implementation data.
All right, so the next step after this is going to be gathering your post-implementation data. You definitely want to use the same criteria as the baseline data that you collected earlier, just to make sure you're comparing apples to apples. Again, this is going to be a multidisciplinary effort, and there's going to be a lot of involvement from the IT department because you're going to have to run many reports and run various programs to actually get the data that you're looking for. Again, use the same parameters, and it's always best to graph it so you can have a visual for your broad audience. So if you just throw out a bunch of numbers out there, it's hard to understand, but if you put it in graph form, it's a lot easier to follow. So here's our inpatient prescribing rate. So we started out at 13% based on defined daily dose, and we've dropped down to 8.5% over the first year of our program. So that overall, that's a 35% decrease in antibiotic prescribing. So that was a great success for us. Inpatient cost. This one fluctuates a little bit. All I have to say about that is our budget for antibiotics as a whole is $15,000 per year. So if you have any complicated infections using Cubicin or Invans and things like that, that really blows your budget out of the water. So if you look at quarter 4, 2016 and quarter 1, 2017, that really kind of busted our bubble in regards to cost because we did have some complicated infections. But overall, it's trending down. So at a smaller place, you can expect that there's going to be a lot more fluctuation because your budget is smaller. You're not a bigger hospital that's consistent. Also, we run very lean with the antibiotics that we do have, so we don't carry many of the broad-spectrum agents or the newer agents that are costly. Again, we really have to look at our costs being in a small facility, so that plays a part as well.
So coming back to me on inpatient sepsis, what we've noticed is a lot of challenges. Specifically, we've had a lot of variation with different hospitals coming in, and there's education that needs to be done. So we look at documentation and also adherence to protocol. So these, as you can see, over time has been challenging. We are getting slightly better, and we're modifying as we go along. If you look on the outpatient side, we're doing much better there, and that was actually the use or the non-use of antibiotics for the treatment of bronchitis is something that we looked at, and as you can see, over time, we have significant decrease in people prescribing antibiotics for bronchitis, so we're quite happy about that. We periodically reassess. We've actually had one revision already to our algorithm based on provider feedback. We have provided targeted education. We continue to do data collection, and then we decide whether or not we're going to continue with the same measures or retire certain measures and switch to a different algorithm to monitor. And then we're targeting weak areas, which documentation is a big one for us with regards to that. If we come back to tips and pearls, bronchitis, the one thing that we did notice is that a lot of times people may not treat with antibiotics for bronchitis, but instead they've been using an alternative diagnosis on these patients with using sinusitis or using pneumonia as a diagnosis, and then whenever they treat for bronchitis, they just don't get antibiotics. I wanted to make sure that my docs in the ER weren't doing that or kind of trying to trick the system, so then I started monitoring overall use of antibiotics by each one of my emergency physicians over a period of time to ensure that we're seeing decreasing overall prescription rates of antibiotics. We have to reinforce the documentation of duration of therapy from an inpatient standpoint. That was something our hospitals were not doing, and that was the one place where we were seeing we were failing on the documentation side. We have to pay attention to trends and non-adherence and realize that possibly your algorithm may have some errors or omissions to it. And what we started doing from a peer review committee is we started including our antibiotic stewardship data in our provider evaluations. And we also started a safer performance measure. Therefore, if you're doing well following your antibiotic stewardship, you'll get a small bonus for those hospital-employed physicians. The other thing I could say is be very persistent. It is a long process, but when you'll realize that with a really good team, you can really make quite a difference.
So back to me again. So what's next? For us at Northern Maine Medical Center, we're looking to work with the lab to get procalcitonin testing, which acts as a marker for bacterial infection. Again, that's a cost-associated item, so we have to budget for it and make sure it makes sense for our facility. Another one is penicillin allergy testing. So our goal is with our outpatients, we have 700 individuals that have a listed penicillin allergy, which really affects how you can prescribe to these patients. And as you know, an allergy has a broad range of how it's defined, anywhere from anaphylaxis to nausea or vomiting. We want to make sure we exclude the ones that aren't as severe so that we can prescribe these patients with some of the penicillins if they do get really sick. So what we're doing for that is we have a system called pre-pen, and we're inviting these patients to come in and be tested. It is paid for by their insurance. We will exclude anaphylaxis patients because the risk is just too high. In addition to that, we're working on certifying different staff members with their knowledge on antiseptics. So from the pharmacist standpoint, the Society of Infectious Disease Pharmacists has a certification just for pharmacists, and I have my staff actually working on that right now.
And that's our contact information, and we're open to take any questions if you have any with regards to our program.
Hello, this is Francis, one of the QIN-QIO members. So my question is if you could please speak to how you engaged the outpatient providers in this initiative.
So I can speak on that. This is Dr. St. Pierre again. What we did is we involved our one of our outpatient physicians, who is a well-respected community member, to actually spearhead the leadership of this. So she was responsible for doing some targeted education to doing this. First of all, most of these providers came to our grand rounds. We do have the advantage at our hospital that the majority of our outpatient physicians here are hospital employed, so that might give us a little bit of an edge to certain areas whereby you may have solo practitioners out in your community. However, I think most of the doctors, once you started comparing them against their peers and providing them with data, no one wants to look bad, so they did seem to significantly improve just simply on that. But I think if I were to say two things, one is stress the importance, get their buy-in, and then two, provide them with direct feedback and data, and that helps to lead to change.
Thank you. So I have a question from chat. Gerald wants to know if you can provide access for your algorithm used for the 8 outpatient measures.
Yes, I can. Yeah, we can provide those to you if you'd like. Just send us an email and we can we'll send you the packet.
Yeah, if you can send it to Amanda, then we can forward it to them after the call. Please. So another question from chat. Jan wants to know if you can provide more details regarding insurance reimbursement for the PCN allergy testing.
This is Dustin. So for the penicillin allergy testing, we haven't started yet as far as performing any of the testing, but we have run through some preliminary payment models with our billing department, and they've assured us that it will work out. But if there's any specific questions, I can reach out to them and kind of get back to you on what the billing codes might be or different things like that.
Thank you. At this time, we'll take a few more questions. You can press #6 to unmute your own line and ask a question over the phone, or you can enter your questions in chat, but remember to send it to all participants. Okay, thank you. There are no more questions. Amanda, I'm turning it over to you.
Hi, everyone. Thanks, Dustin and Dr. St. Pierre. I just want to let everybody know the pharmacists who are claiming continuing education credit for this webinar. The ACPE code is Antibiotic. You'll be able to enter that information when you complete the session evaluation. Others who complete the evaluation will receive a certificate of attendance. Here is everyone's contact in the New England QIN-QIO. If you're interested in any information or want to reach out to us for any kind of assistance or connections, just here's all our contact info. The Learning Center is our virtual learning system through the QIN-QIO. It hosts free courses available to all healthcare providers. As healthcare providers, we know that you have busy schedules, so courses are laid out in bite-sized chunks, and some even have continuing education credits. So, for example, you could take a pre-test and beginning lesson during a break. On the next day, you could continue the lesson as the system will ask if you want to start where you left off. So it's also mobile-friendly, so you can begin a course at work on your computer and continue on your tablet or phone at home, or when you're out and about, like waiting for your oil change. In order to keep things up to date and relevant, courses are reviewed by subject matter experts. We also welcome feedback from users. If there's a course topic that people want to see in the future, we have surveys in place to capture those requests. Providers can expect to see courses sorted by healthcare setting, but they are not restricted from any courses except our internal staff training. Managers can get reports on the courses their team is taking, number of times, their pre- and post-test responses and grades, and any relevant feedback captured. So this can be very helpful in identifying gaps or opportunities for reinforcement of training. So we invite you to visit the Learning Center at learningforquality.org and follow your healthcare settings instructions for creating a new account. If you have questions, please send an email to learning@healthcentricadvisors.org for assistance. And don't forget to follow us on social media to get important alerts, news, and more. So I'll now pass this back to Doreen to close today's session with some additional housekeeping items.
Thank you, Amanda, and thank you for a great discussion. I have just a few last announcements before we end today's call. When you close out of this webinar, an evaluation will automatically appear on your computer. We will greatly appreciate you completing that evaluation. If you don't have time right now or currently sharing a computer with someone else, you will receive an email tomorrow containing a link to the evaluation. As I mentioned at the beginning of the webinar, the PowerPoint presentation is currently posted on our website. Within the next few business days, a recording and transcript will also be added. The link for this will also be included in tomorrow's email. Thank you again for this great presentation and to everyone for attending. Have a wonderful day. You too. Thank you.